Next slide. This morning, we are partnering with the California Evidence-Based Clearinghouse to present a review of well-supported mental health programs on the Title IV Prevention Series Clearinghouse. Our presenter is Jennifer Rolls-Roots. Jennifer's work has focused on children receiving services through public sectors of care, including child welfare and mental health systems. Previously a research coordinator at the Child and Adolescent Services Research Center, also at Rady Children's Hospital. She is now the director of the Cebc, or California Evidence-Based Clearinghouse, and of the California Training Institute. So we would like to welcome Jennifer this morning. Jennifer?
Thank you. Thank you very much for having me. And I'm very glad to be sharing information on the programs that will be available in California through the FFPSA funding. So as Dana said, I am with the California Evidence-Based Clearinghouse. For those who are not familiar with it, the mission of the CEBC is to help spread the use of evidence-based practices within the child welfare system, as well as in other child and family serving systems. And the CEBC has two main components, the program registry and an implementation section. So while I'm with the CEBC, today I'm really going to be talking about FFPSA, Family First Prevention Services Act, and their rated programs. So I'll be taking off my CEBC hat for just a bit. All right, so what is FFPSA? Hopefully most of you have at least heard of it, but in case not, I'm going to give a very brief overview of what it is and its rollout in California. So FFPSA stands for Family First Prevention Services Act, and it's federal legislation. One thing I do want to touch on is that FFPSA is huge. So there's lots of pieces of it that we aren't going to talk about at all. We are really just covering FFPSA Part 1 today. So we won't be covering Part 4, which is more about congregate care. We also aren't going to cover the FFPSA rating process in a lot of detail. I'll give you links to where you can get more information and we'll talk about the ratings, but it's a complicated process, so we're not going to use this webinar to go over that in huge detail. Also, I'm going to talk about the California plan for FFPSA, but again, I'm just going to give you like the tip of the iceberg. I'm not going to give you all the details. We'll drop links and we'll share those with you afterwards as well for where you can go to get additional information. One place you can go to learn more about FFPSA in California is the CDSS website. So I'm going to ask that we drop a link for that if we haven't done that already. And you can check out the website after the webinar. It has great information about all of FFPSA in California. One reminder, any links that we drop today in the chat will be sent to you via email after the training, so you don't need to try to frantically write all those down. All right, so FFPSA was passed into federal legislation, was passed into law in February of 2018. It's got a lot of provisions, like we said, most notably Part 1, which we'll be talking about today, which implements new funds for prevention services. And so what this will do is allow federal Title IV dollars to be used for specific evidence-based services when a child is at risk for out-of-home placement. In some ways, it replaces the Title IV waivers that we used to see, but it's, again, got different criteria. It's got different eligibility. So in order to be eligible for these services, the child has to be at imminent risk of foster care, imminent risk of out-of-home placement, and we can serve both the children and their family members. Part 1 also applies to pregnant and parenting youth and their children who are who are considered an imminent risk. The evidence-based interventions that can be funded under FFPSA Part 1 do need to meet certain criteria, and that's what we're going to cover today. First, they have to be listed on the Prevention Services Clearinghouse. That's the FFPSA Federal Clearinghouse, and we'll drop a link to that if you haven't been there. And they actually just updated their URL recently, so make sure you've got the new one. Eligible services for reimbursement have to be in certain categories: in-home parenting, substance abuse prevention and treatment, and today's topic, mental health prevention and treatment. Additionally, the federal law does allow for evaluating services to help kind of boost their evidence and hopefully get them raised in level over time and get them up to higher levels of evidence, well supported, for example. Also, these programs that you pick have to be listed in the California plan. So currently there are 10 well-supported programs that are in California's plan that can be funded under FFPSA Part 1 here in California. I believe the plan is over time to amend our plan to add in additional programs, but right now this first iteration, there's 10 programs that have been approved. So what's the goal? We're really trying to reduce entry into out-of-home care by addressing safety threats and helping children remain in their homes with their families. That's the the basic purpose. So we're taking Title IV dollars, which have typically been used to fund out-of-home care, and now being allowed to use them to prevent out-of-home placement in these certain situations. Now, to support the implementation of FFPSA in California, the state passed something called Assembly Bill 153, AB 153. And this expands on FFPSA by offering additional optional funding that requires counties to engage partners in the development of a comprehensive plan, which includes all levels of prevention, primary, secondary, and tertiary, and allows for services in addition to those funded under FFPSA Part 1. So the development of this comprehensive plan requires collaboration with community partners, public agencies, tribes, individuals with lived expertise, and other key partners in each area, in each county. The state has realized that our government agencies and community partners are in varying levels of understanding of primary prevention strategies, and what it will entail to develop a comprehensive plan will require using a true cross-sector approach, bringing all the players to the table. Also, for those agencies who really haven't begun to move in a primary prevention direction yet, the law supports the ability to do that work. It allows for administrative dollars to support the development and the planning process. And so I'm going to ask that Dana or Jess drop the link to a webinar series that CDSS, California Department of Social Services, is doing in coordination with CalTrin and Strategies TA. That's really talking about what is prevention? How do we reimagine prevention in California? Some of the webinars are completed and you can watch the recordings online. And then, as Dana said earlier, there are several more to come. So what we're doing in California is really kind of blending or merging together the federal and the state law, connecting this. So helping these two statutes work together. Again, we're recognizing that we're not starting from scratch. Many counties have already been working with OCAP, with the Office of Child Abuse Prevention, to build local capacity for prevention. And we want to support that, provide additional funding through California's Family First Prevention Services program. We also want to expand opportunities for additional jurisdictions to participate in this process. So in addition to the current counties that are working on prevention plans, I think the goal would be to have every county moving towards primary prevention and building that comprehensive plan. So I'm going to go ahead and skip. So again, the California plan goes beyond the federal law. It will allow funds to be used for things that can't be funded through FFPSA Part 1. So it's bigger than just that. And so what the state has put together is what we're calling a roadmap, what this looks like. And this is a way to help counties who want to kind of build this comprehensive plan and implement these services that can be funded under AB 153, FFPSA Part 1, et cetera. Again, we've had a webinar on this. I think we can drop the link for this roadmap slide. Lots more detail, but just to touch on it, most counties are in the guidance and information and the capacity building phases way over here on the left-hand side. And again, there was a whole webinar that was presented by CDSS in March, and that gives you more information. The recording and the materials are available online. So why does all this matter? I think the key thing with FFPS and the California rollout is that this is not going to be just driven by the state or by the child welfare system. Programs and services will all be selected through a comprehensive prevention planning process. And the requirement for that process is that the community be involved, FRCs, CAPCs, community-based organizations. people with lived experience, lived expertise, et cetera. And for those of you who maybe hear from those community-based organizations, keep in mind that this is a potential funding source. Our expectation is that many of these services will be contracted out in the community, working with community-based providers who will now be an integral part of the community pathway of getting families into preventive services before they get involved in child welfare. All right, so now let's get to what we're really here for, talking about the specific programs and the differences between them. So FFPSA is arranged under service categories. And as I mentioned earlier, there are 3 service categories that we'll cover in this webinar series. Today's webinar will cover mental health services. The next 2 will be on in-home parent skills-based programs and substance abuse prevention. So what is a mental health service? Not too complicated, but they do, of course, have criteria because it's federal legislation and they like to put in lots of words. So reduce or eliminate behavioral, emotional disorders or risk for such disorders. So clearly prevention is included. Can target any mental health issue, no diagnosis is required. Can be delivered to children, youth, adults, families, can employ any treatment modality, and can have any therapeutic orientation. Really, the only restriction is that the service cannot be medication only. So this is not just to cover medication administration. There has to be a psychosocial, a therapeutic, some sort of additional component in order to cover it. In addition, in order to fund a service under FFPSA Part 1, the program has to meet criteria of a well-supported rating on the FFPSA, the Prevention Services Clearinghouse. So I'm going to touch on how you get rated there very briefly, but if Dana or Jess can drop a link to the details of the rating process. Basically, in order to get a well-supported rating, you have to have at least 2 contrasts. They use the term contrast, carried out in usual care settings that showed favorable effects. There's more detail in here, but just basically a contrast is a comparison. So it's what outcome did you look at? Maybe you looked at depression ratings, on the CBCL or the Beck Depression Inventory. That would be one contrast. You compared the intervention and the control group on that measure. So in this case, you have to have at least 2 contrasts to meet the well-supported rating. In addition, at least one of the contrasts has to have shown that the effect continued at least 12 months after the end of the treatment. So again, a lot more detail on their website, but that's the flavor of it. At least 2 contrasts, at least 12 months to get the well-supported rating. Okay, so currently there are 4 programs that meet these criteria and that are written into the California plan for FFPSA. Again, the anticipation is that over time, California will amend and add in more programs, but this is what we've got right now. So we have family checkup, functional family therapy, MST, multisystemic therapy, and parent-child interaction therapy, or PCIT. And we'll cover each one in more detail next to really give you a flavor of what each one is and help you start thinking about whether these are interventions that might be appropriate for your agency, your county, et cetera. So first, family checkup. This is one that I find that people aren't as familiar with. So it's alphabetically first, but it might be good for folks to hear more about it. So this is a brief strengths-based intervention. It's for a broad range of ages, 2 through 17. And what it really does is it tries to build parenting skills, family management practices. So a little bit more kind of getting at, helping people learn how to parent better, run their family with a goal of, preventing issues from occurring. It is for children, broad range, 2 through 17. And there is several different components of the program, and they're done individually with the families. So originally, this program was done in like doctor's offices or other places where the family was there, often for another purpose. And you would do these sessions, and then they get a personalized plan for what the follow-up services are that they need. And all of those follow-up services would vary in intensity and duration based on the specific needs of the family. So the goals, as you can see, very quite broad, lots of them. Really, the main goal, I think, is the primary one. They want to improve children's social emotional adjustment by providing support for parents to encourage and support positive parenting and reduce coercive conflict. So basically, again, by improving parenting skills, what they want to do is really prevent mental health behavioral issues from occurring, and if they are occurring, to help reduce them. So as I mentioned, there's several key components or essential components. The first is that initial interview with the family that involves rapport building and some motivational interviewing techniques to get at what their strengths and the challenges are related to the family and their parenting. And then there's a more formal assessment with questionnaires, et cetera, and they actually do a videotaped observation. And then lastly, tailored feedback that goes over what the assessment showed and what are the service options that are available to the family that are specific to their needs. So while the intake and the assessment is the same across the board, the outcome, the follow-up services are going to vary based on the needs of the family. And I should point out here that there is everyday parenting, which is kind of a standardized parenting management program, is often one of the recommendations. That's how you would build your parenting skills. Okay. All right, so now let's get into the evidence for this one. So again, each program is rated by the Prevention Services Clearinghouse, and they actually rate each individual study. So it's a pretty detailed process. Again, I'm going to refer you to their website for a lot more details about how this is all done. But basically, they have a standardized process for identifying studies. In this case, they were able to identify 22 separate studies of family checkup. However, only 5 of those studies met their criteria for review, for participating in their review process. And you can go to the website, they'll explain exactly why the other 17 studies were not included. Again, very detailed. Once a study is deemed eligible for review, each study then undergoes a very rigorous design and execution review. And then they rate each of the studies high, moderate, low. And so what you can see here is of the 5 studies that were eligible for inclusion in PSC, in the Prevention Services Clearinghouse, 3 of them had high rating, meaning very high quality. 1 was moderate and 1 was low. Okay. And what did they find across those 5 studies? So first we'll look at the child findings. And what's interesting here is that although they looked at a lot of different areas, behavioral emotional functioning, cognitive functioning, educational achievement, they didn't find any positive or favorable significant effects at the child level for this program. However, what they were able to find were favorable effects on positive parenting practices. And so I won't, again, go over those all in detail. You can see them on their website. But for example, one of the outcome indicators they used here was the home measure, the home observation of measurement for environment. And so they were able to see a positive or favorable impact on that measure over time. So what I'm going to give you here are just some examples of the study populations. Again, multiple studies conducted, so I'm not going to go through and list all of them. You can see that information on the CBC website as well as on the PSC website. But I just want to give you an idea of who is involved in the research on this program. And this can help you see whether the populations are similar or different from the populations that you work with. So we can see here, just pulled kind of 2 examples. And this is using the exact wording that was in the study. So that's why the wording, the descriptions for the racial ethnic categories is a little bit different. But obviously you can see they had some variety in terms of who was involved. And in the samples themselves, they were pulling them from people who enrolled in the WIC program, Women, Infants, and Children. Another study recruited from public elementary schools. And another study was actually a universal program. So it was open to everybody in the community. So this section is on support for implementation, and this tells you what the program has available to help you get started. So pre-implementation materials would be assessments or guidance documents. So in this case, the Family Checkup program reported not having any of those available for agencies to use. They did, however, have formal support. They do have an organization that can support you through your implementation process, and that's the REACH Institute. In terms of fidelity, which obviously is very important, you need to know if the program is being delivered as it was intended. They do have fidelity measures available. And then lastly, implementation guides. Do they have written materials that you can refer to specifically about how to implement the program, kind of the day-to-day setup considerations? And those are available on the Family Checkup website. Who can deliver Family Checkup? First is an education level. We expect, or they expect, a master's level clinician with some sort of clinical experience. Not surprising, clinical program. And they offer training in 3 different formats. So they have in-person, a 2-day training, they have an online training, and they also have a hybrid model. So looks like they've moved towards the COVID technique of needing to have multiple options of how things can be delivered. Okay. All right, so that's a quick summary of Family Checkup. I'm going to move through the next 3, and we'll cover exactly the same areas so that you can make comparisons across these programs. And again, lots more information available on the PSC and also the CEBC website. All right, so functional family therapy. This is a short-term, more of a prevention program for at-risk youth who have been referred for behavioral and emotional problems. And there are 2 organizations that, that support or promote FFT, so I put both their logos at the bottom. Target population, this is older, so 11 to 18. And we're often looking at kids who've been referred for already having behavioral emotional problems. They might be referred by juvenile justice, mental health, school, child welfare. So a little bit higher on the spectrum of issues. Here, it's a more traditional face-to-face intervention. So we've got therapists who are meeting with the families, 60 to 90 minutes, often by phone as well. And it's an average of 8 to 14 sessions over a 3 to 6 month period. So obviously lots of variation there, but families are what we are. And so we need to have some flexibility on how often they meet, how much service they need, et cetera. The goals of FFT are to eliminate whatever that referral problem was. So delinquency, behavior, violence, et cetera. And then obviously to correspondingly increase pro-social behavior like school attendance. And also to help the family, youth, parent, child, et cetera, everyone to grow their positive skills. FFT has 5 distinct phases. So again, if you're familiar with clinical therapy, these are going to look pretty familiar. So engagement, how do we get people involved? How do we motivate them? What's the relational assessment between all the family unit? Driving behavior change. And then how do you generalize the skills that you've learned? So each phase has its own goals, risk and protective factors that are addressed, its own assessment, et cetera. So again, not getting into that detail here, but you can see all of that on the internet. Looking at the evidence for this, again, we saw a large number of programs that were identified. Only 9 were eligible for review. And then you can see the breakdown here, 2 high, 4 moderate, and 3 low. And the child findings. We did see favorable effects in several child areas for this intervention. We saw effects in behavioral and emotional functioning. We saw a large number of effects in the substance abuse area. And we saw effects in the delinquent behavior area. And some examples of measures that were used here would be the strengths and needs assessment, the Beck depression inventory, and then also very concrete administrative outcomes like days of alcohol or drug use, or convictions for property offenses, things like that. On the parent side, we did find favorable effects, or I should say the FFT researchers found favorable effects on family functioning. So these were things like the family environment scale, the conflict tactic scale, verbal aggression subscale, et cetera. Okay. Samples, examples of population studied. Not surprisingly, given the type of study that it is, or the type of intervention, it's adolescents who have alcohol problems or a history of aggressive behavior, or in one study who'd already been in contact with the police. And we were seeing relatively diverse samples, decent inclusion of racial ethnic minorities. So a broad range of samples, but definitely very targeted at adolescents, given the nature of the program. Support for implementation. They actually have a good amount. So they have pre-implementation materials available publicly on the website. They have a formal statewide coordinator, and there is one here in California who assists with rollout. They do have Fidelity measures available, and then they also have implementation guides and manuals that are available from FFT during the training process. Requirements: education, you need to have a master's level. And as I mentioned before, there are two groups that are that provide training on FFT, and they train a little bit differently. So I've included them both here, similar, but just slight differences in how they train on them. Okay. All right, so that's FFT, which is an adolescent intervention. Here is another more adolescent-focused intervention, multisystemic therapy. So this is a more intensive treatment for troubled youth. It, again, aims to promote those pro-social behaviors and to reduce criminal activity, mental health symptoms, out-of-home placement, and other issues in youth. And again, it targets adolescents, 12 through 17, and their families. They can be at risk for or already engaging in these behaviors, and particularly could be at risk for out-of-home placement. This is a very intensive service. So typically we're seeing multiple weekly visits between the therapist and the family, and services typically last 3 to 5 months. And the goals, not surprisingly, we've got the elimination or reduction of the frequency and severity of these behaviors, and then learning coping skills. How do they deal with stressors in their environment? For parents, similar things, learning skills to how do they address, the issues that are coming up, how do they deal with parenting stress, and how do they support their youth, their children, as they're learning how to, use these coping mechanisms rather than acting out substance use, et cetera. So MST addresses these causes of delinquent antisocial conduct by really trying to get at what is driving the behavior. Why is the youth acting out this way? And then they use that information to kind of personalize how they're going to address that. So again, each family is different. So each implementation is going to be slightly different to address the individual needs of the family. But what is consistent is that services are available 24/7. You get crisis management. Again, these are kids that are probably higher on the acuity level who may need support at 2 o'clock in the morning. And these services have a way to get that to families so they can meet them when they're in need. So it's a very intensive service delivered for about 3 to 5 months. And the therapists have a very small caseload. And that allows them to actually meet the client needs so that they can handle the intensive services they're delivering because they're serving a small number of families at any given time. For evidence, we saw 28 studies were identified. 16 were deemed eligible for review under the Prevention Services Clearinghouse. And of those, you'll see the rating breakout here: high, moderate, low. I do want to point out that the Prevention Services Clearinghouse has a limit on how many articles it reviews in detail. So if a program has 15 or fewer eligible studies, then it reviews all of them. In this case, MST has 16 studies. So what ended up happening is all of the studies get assessed for whether there was any risk of harm from this intervention. But only 15 studies are reviewed using the very detailed design and execution standards and given that rating of high, medium, low. Again, a lot more details on the website if you want to read about how they determine which 15 articles they review and so on. But clearly 15 studies, so lots going on there. MST, lots of findings, lots of favorable effects. So clearly, behavioral and emotional functioning is showing a lot of effect, which you would expect given the goals of the program. Some of the tools they used to assess this were things like the Disruptive Behavior Disorder Rating Scale, the Child Behavior Checklist, the Strength and Difficulties Questionnaire. So for clinical folks, you're probably familiar with a lot of those. Okay. Didn't really see effects in social functioning or cognitive functioning. But definitely much going on in the behavioral emotional functioning area. Out-of-home placement, they also did see effect there. And there was effect on things like self-reported delinquency, property offenses, number of offenses in the past 6 months, et cetera. So again, just as you would expect from the goals of the program, more findings in that delinquent behavior area because that's a target of what they're trying to get at. On the adult side, they also saw significant effect. So again, keep in mind, we're trying to help parents parent these children better and support their children as they deal with developing coping skills that are more positive for the stressors in their life. So we are seeing positive parenting practices increase, more effective use of positive discipline. Things like the Alabama Parenting Questionnaire were used. And we also saw that parent and caregiver mental and emotional health improved. You reduce stress in the family, that's going to reduce stress on the parent. We saw improvements on family functioning as well. So again, for these really high acuity kids, we were adolescents, they were able to find some pretty significant outcomes across a range of domains. The studies, again, not surprisingly, we're seeing a lot of high end. So we're seeing adolescent sex offenders, juvenile offenders, adolescents who are already showing some pretty significant behaviors, students who were pulled from what they call moderate intervention programs. So these are kind of self-contained classrooms for kids that might have higher needs. And then again, here's a couple of examples of the racial ethnic breakdown from studies. Much more detail on those studies on both the PSC and the Cebc website if you want to read more about them. Pre-implementation support. MST has probably one of the most extensive implementation support processes of any of the programs that you'll see. It's called MST services. So very extensive. They will take you through this entire process, start to end. They have pre-implementation materials that are, in many cases, are actually required because they want to make sure that you know what you're getting into and that you're going to succeed. They have formal support, both from MST services and a large number of other network provider organizations, fidelity measures, guides, et cetera. So lots of stuff there. In terms of training, what we expect to see is that the supervisor is master's level, and there is some ability for the therapist to not have master's degrees, but that has to be kind of coordinated with MST. So supervisors, definitely masters, some flexibility on the clinicians. In order to deliver MST, you have to work for a licensed MST team or organization. So one individual person cannot just deliver MST on their own. You have to be part of a larger group. And so it is a pretty significant endeavor. It's a 5-day initial training, and that's for therapists, supervisors, other staff, et cetera. And then you also, to maintain fidelity and quality of services, you participate in ongoing trainings. So these are quarterly booster sessions, weekly consultations, et cetera, to make sure that the intervention is being delivered well. All right. Now let's go back to an intervention that's more for the younger kids. So we just had 2 that were more focused adolescents. Now we're going to get to parent-child interaction therapy, which is more on the younger side. So in this intervention, which is really neat, I wish I had time to share a video, but it's pretty cool. Parents are coached by a therapist in their behavior management and their relationship skills. So it's geared at younger children. And again, what you're trying to do is improve positive parenting behaviors with the goal of reducing externalizing child behavior and improve the quality of the parent-child relationship. It targets young kids, 2 to 7, okay? And it's been done with bio parents, foster parents, other caretakers, so a caregiver parent figure. It is typically done in weekly hour-long sessions, 2 to 12 sessions, depending again on the needs of the family. So it's not just a set number. It can increase, decrease, depending on what the family needs. The goals, lots of them here, building those relationships between the parent and the children using positive attention strategies, increasing the child's feeling of safety and calm, decreasing frustration and anger, all of these things. So great way to increase parenting skills with a goal of reducing child behavior issues. So there's 2 main components. sorry, go back to this one. There is a child-directed interaction part, and there is a parent-directed interaction part. Not going to get into detail, but basically as it sounds, there are some times where the child is actually driving what's going on and other times where the parent is driving what's going on. And that's probably more than we need to get into for this one. In the essential components, so for those who are not familiar with it, what you're really doing is the therapist is coaching the caregiver live. So they often, they're using a bug in the ear, basically like a wireless, headset in their ear, so that the parent can hear the therapist coaching them from behind a one-way mirror. So you'll have the parent, the child in one room, the therapist in another observing, and they're live coaching the parent on how to react or how to respond to behaviors, activities, et cetera, as they move through the process. And they're helping those parents to master competencies. So therefore, there's no fixed length of treatment. Some parents might just need a little bit extra to get where they need to be for healthy parenting. Lots of studies here, 36 studies, 21 were eligible for review. So more than 15 studies. There's a small number that they kind of held off to the side that showed no risk of harm. But again, a range of high, moderate, and low rated studies. And here we saw many effects on child well-being, particularly in the behavioral and emotional functioning area. And these were measures like the Child Behavior Checklist Externalizing Problem Scale, the IBERG Child Behavior Inventory Intensity Scale, or the Behavioral Assessment System for Children Hyperactivity. So multiple areas that looked at behavioral and emotional functioning showed effect. On the parent side, as you would expect, lots of parenting effect as well, particularly in the positive parenting practices. We're helping parents learn how to parent better. And so we're seeing significant effects there. We're also correspondingly seeing some effect on parent caregiver mental and emotional health as they're feeling better about their parenting skills, less stress in the family, and so on. So some of the measures that were looked at here were things like the dyadic parent-child interaction coding system, so literally coding interactions between the child and parent, and then behaviors like use of corporal punishment or results on the parenting stress index. Again, the PCIT studies are pretty varied. Large minority samples are being used. Some of the examples where these studies were pulled from, families who were seen at a community mental health clinic. We have some very specific studies. There was a large study done in Hong Kong, so showing whether this works with an ethnic Chinese population and in a Hong Kong setting. Also, autism spectrum disorder. So we had kids who had both autism and behavioral problems. So many different variety of samples have been used to examine PCIT. PCIT did not provide information to the Cebc about whether they have support for implementation. They do have Fidelity measures available though. And for training requirements, you have to be a licensed mental health provider with a master's degree, or you have to be a doctoral student who's under the supervision of a licensed mental health provider. It's about 40 hours of training, and they do have an online option, but at least 30 of the 40 hours has to be face-to-face. All right, so that was a lot of information on those 4 programs, but hopefully gave you a flavor of what they are. And it's pretty clear just from looking at them that they are not one size fits all. The type of agency that wants MST is serving a very different population from an agency that's looking at PCIT. Okay, very different ends of the spectrum, but all falling under this mental health services prevention and treatment area under FFPSA Part 1. So that brings us to the next piece of the intervention, which is which program is really the best fit for anyone, any individual agency or county or for the needs of your system. So we'll talk about that and what the Cebc can offer. So the reason we start with this is careful selection. You have 4 programs that are fundable under FFPSA Part 1. And if you're going to adopt one, you want to be really careful how you pick it. And the reality is that the success of any practice is going to be dependent on actually having made a good selection. Did you pick the right one? And the right one being for your particular situation, for your needs. And obviously, there would be negative consequences of adopting something that is not really appropriate for your needs. You've got wasted time, wasted money, and then obviously wasted impact on families. If you're not getting the outcomes that you're looking for families and children, that's obviously a pretty severe negative consequence. Another reason we like to point out about careful selection is that while we often jump to adopting a new program, at the CEBC, we want to be clear that a solution for whatever issue you're having is not always just bringing something new on. It might be changes to internal processes, making sure that the right families are getting to the right service. So if something's already available in your community, do people know about it? Are they getting referred there appropriately? Is there enough capacity? So we frequently hear about great programs that are already working, but there's huge wait lists. So could you increase existing capacity at existing programs to meet need rather than trying to bring in a completely new program? And then lastly, there's always locally developed programs that seem to be working. And so we want to think about building evidence for those programs. How do we show that the programs that you are already using are effective? And luckily, as I mentioned briefly earlier, there is some ability in FFPSA to use some of those funds for evaluation purposes to help grow the research base for some of these programs to get them onto the clearinghouse and get them fundable. All right, so now I'm going to put my CEBC hat back on more firmly, and we're going to talk about what does the CEBC have that can help support you as you're selecting not only just for FFPSA Part 1 for looking at these 4 programs, but more broadly as you're making decisions about selecting programs in general. So besides what we covered today in that comparison earlier, the CEBC program registry has a lot of other information. So I've listed some of those here. All of these could help you determine whether any particular intervention is the best fit for your needs in your community. So things like, what are the required resources? What languages are the materials available in, and so on. We also have plain language summaries of the research studies. So if you're the kind of person who wants to really read the detail, that's all on there. You can go through and read the more detailed information about the studies and not just rely on the particular rating. The CEBC also allows you to compare multiple programs at the same time. You can select programs and then you'll get the report that shows you on all the different factors how they compare directly. So on the CEBC, here's a screenshot of the website if you haven't been there. We do have an entire section of the website that's all about selecting and implementing programs, lots of tools and worksheets that you can apply locally. And so we'll walk through some of those today. A key thing is that we have an entire guide, 100-some pages that you can download from the website and actually work through at your community, at your agency, whatever the group is. So we use something called the EPIS framework to support our implementation work. And EPIS stands for, as you can see here, exploration, preparation, implementation, and sustainability. So the CEBC focuses on the exploration phase of implementation. So we want to help organizations figure out what are their needs and what interventions would address those needs. That's the exploration phase. That takes you from examining the problem up to like selecting the intervention. Once you've selected the intervention, now you're moving into the preparation phase. And in that case, you're going to work a lot more closely with the intervention developers, with the program developers. So the exploration area is really where the CEBC can come in. So let me give you an example of how this guide has been used here in California. So the CEBC was contacted by an agency that was looking for a parent training program. They wanted to include it in an upcoming proposal. So we worked with them using both the guide and 2 phone calls to help identify what the goals were for the parenting program. What were they trying to achieve through a parent training intervention? We also discussed with them, what have they already been using in their community? How had that gone? Was it working? And we wanted to learn more about the local community needs. Who's the target population? Who are they working with? They were then able to identify from the CEBC 2 potential parent training models, which they did some additional work with, and you'll see the worksheets in a few minutes, including having some stakeholder discussions. So getting that team together to talk about what the options are. They also talked with the program developers. And lastly, they talked with other agencies that have used those models to get a feeling for how it went and what they thought about it. And then they were able to make a final decision on which of the 2 models to select for their needs. So all of that is kind of supported through the guide. You can work through them on your own. For those of you who are here from California, actually the CEBC can help you through some of that process. Like we mentioned, we can either work with you through phone, through Zoom. We can help you go through the process. It's not going to be 100 hours of support, but we can at least do some initial support to get you on the path and kind of support you at various phases of that selection process. All right, so here are the CEBC's key steps in exploration. Just figuring out, again, exploration, figuring out what your issues are and what you need to do to address them, identifying if a new program is appropriate. So the first step is always putting that team together that's going to work on this issue. And we want to be clear that the team should be quite broad. So not just professional staff, so not just agency staff, but also stakeholder representatives, people with lived experience, people from the community. So you're getting a kind of a broad perspective in that work group. And it's also important that all of those perspectives be actually incorporated, that they're not just tokens, that you're actually allowing and encouraging all the members of this team to give their input, give their thought, and contribute to the decision-making process. So once you've got your group together, you kind of explore the problem in more detail. So what are the areas? What are you trying to address with a potential new intervention? And so we have let me just run through the rest of these, and then I'll go into them in more detail. So exploring the problem, and then we get into a needs assessment. We look at what the potential solutions are, and then discuss the program fit. So we're going to talk about each of these in more detail and go over the tools that are available. A key step in exploration is always working with the developer. This is going to be a lengthy process, and you're going to want to have a developer, a program developer, or a implementation support team that you're comfortable working with, that you feel you can work with for the next 2, 3, 4, 5 years. And then lastly, I'm a research person, so I'm always going to say, make sure that you have a written summary of what was done in this exploration phase so that you can clearly justify why any particular program was selected, what decisions were made, who was involved in the process, and so on. So it just kind of, makes it more legitimate if you've got good record keeping of what the process was and how the decisions were made. All right, so let's move into the details. Exploring the problem. So this is beginning to look at, what is the data available? What are the population demographics? What indicators of need do you have? Things like referral or retention rates, number served, wait times, et cetera. So if we can drop a link to where you can download this tool, but basically it's a way to start identifying the key issues related to whatever this problem is. At this point, we would also recommend that you start thinking about a root cause analysis. So this could be like a fishbone diagram. We also often do like the ask why 5 times. So it's really getting at what's the root of the matter, so that you can address that and make sure that you're addressing the correct problem and coming up with an intervention that's really going to meet your needs. A needs assessment is also going to be key here. So you need to examine your community. You need to look at the data that you already have. So always start with data that you have. And if you're part of the child welfare system or mental health, other agencies, you probably have a lot of data already. So be sure that you're leveraging the data that you currently have. You want to identify gaps or barriers in your current services, in the current service array. Are there populations that are underserved? And then how do you move forward. Again, we have a tool for this, and that you can use this tool. It's not rocket science, but it's a way to help you start thinking through what the needs are, what's going on currently in your community. Also be thinking about, what are you currently delivering? What services are currently being offered for this issue or this population? How is that working, et cetera. Lastly, you can think about collecting new data. So you might want to do focus groups, surveys. We often recommend things like chart reviews. Go back through the data that you already have and see if you can get additional information from it. But recommend that you don't jump right to new data collection. Start with leveraging what you already have. All right, identifying potential solutions. So depending on whether you're applying this for FFPSA Part 1 or for your own internal needs, it's going to be a little bit different. FFPSA Part 1 in California, you have 5 mental health programs that are currently approved in the plan. But you can still use this, this process to identify which of those is a good fit for your needs. If you're looking more broadly, if you're applying this selection process outside of FFPSA, then you can kind of go through, again, this entire tool, which will help you think about, identifying from the entire body of programs that are out there, which ones are going to be the best fit for your needs. And to do that, we have what's called the selection guide. And of course, it has an accompanying worksheet, because we like a tool for everything that you can write on and you can fill in. It's available as a PDF. You can start filling that in. And what this does is allow you to summarize the potential programs and compare each program that you've come up with across domains to help you see whether it's going to be the best fit and whether there are issues that you have to consider. And we know that if, let's say you're looking at 3 different programs, there may be a clear best fit, but there also may be pros and cons for each one that you're going to have to weigh in that implementation team that you set up earlier. So this really strives to help you identify what are those concerns or questions that you have and how can you address them. And within the guide, we're going to give you some real world examples of what those are. So let's talk about what the domains are first. So things like ease of use, external compatibility, knowledge requirements, skill set, risk, etc. Lots of detailed information on the CEBC on each of these. And just keep in mind that when you're going through the selection process, you're going to want to consider all of these and again, adjust those pros and cons for each program. So let's give a couple of examples. So external compatibility sounds very technical. So one of the key issues that often arises with practices is that you want to make sure that it's compatible with who you want to serve with this. So you want to look at the practice itself and make sure that the beliefs and values of that intervention are in line with the local community. Also, is it compatible with the referral sources? Will they feel comfortable referring, clients to it? And this is where it's so important to have those stakeholders involved from the very beginning. You want to make sure that the people who are the population that's going to be receiving this approves of it, that this is a program they feel comfortable with, that they would want to receive. Okay, so external compatibility, how much does it work within your settings? We also have financial considerations, a relative advantage. So you obviously don't want to get into a situation where you're already partway through your training and implementation, and then you realize that the cost to implement this EBP is way beyond the the financial resources you have. So you need to consider cost from the very beginning, and it needs to be part of your decision-making process. You want to think about costs, not just for the service delivery, but costs for training, consultation, et cetera. So some of the key questions here, what are the financial resources that exist, both short and long-term? So FFPSA Part 1, AB 153 are giving you additional funding streams that can be used, but you, your organization, your agency will need to consider what those will cover, who's the payer of last resort, et cetera. Lots of technical questions that may impact on your decision-making process. Some of these have more extensive upfront costs for training. Depending on, do you have to send 10 people to a training in another state? Or can you have a trainer come to you, etc.? So financial things to think about. And last example we'll give is addressing the match of the skill set. So what is the education level? If you are thinking about bringing a new program into your agency, you have an existing staff. Do any of the potential programs fit the existing staff that you have? Or are you going to have to go out and find a whole bunch of new staff? So if you are largely, master's level staff, great. It looks like you're a good fit with all the mental health interventions that we talked about today. But if you don't, if you're using, paraprofessionals, bachelor's level, you may need to consider whether some of these are a good fit. And are you going to be able to recruit the people that you need to address the skill set requirements of any particular intervention? All right, so just a couple of examples of how you look at the fit of each of the programs. All right. So after you've kind of identified the fit of programs and thought about that, that next step is always working with the program developers, not only to see if you get along with them, if you want to work with them, kind of what their philosophy is, how there's going to, how that's going to work. But another key question that programs often have or agencies often have when adopting an intervention is, can we adapt? Can we make changes to an EBP? And I'm always going to tell people that if you want to talk to the program developer before you think about making any changes. And there's a few reasons for that. One is you want to make sure you really need to adapt prior to even adopting the program. There are some studies that show it might work better to actually try the practice as it was originally designed first, see how it works, and then make modifications. And there is some evidence that that these practices work exactly as they're originally intended in a wide variety of populations. So use caution when adapting, and that's when you really want to work with the developer to make sure you're not changing anything that's going to have unintended consequences, that's going to impact on a key component that you may inadvertently change. So when we talk about adaptation, I find it helpful to do kind of this red light, green light that makes it easy for folks. When I talk about green light changes, these are usually really minor things. So they're often made, like we talk about cultural adaptations, to make something more accessible to the community. So you might take all the images in the training materials and make them authentic to your community, to match the community that you're delivering to. You might change the name of the program. So you might want to, instead of calling it parent-child interaction therapy, you might come up with a name that feels a little bit better to your community. Obviously, things like statistics or language, you want to adjust all of this stuff to the needs of your community. And that's typically okay. Again, run it through the developer. When you get into the yellow and red light changes, those are more substantial changes to the intervention itself. These are more questionable. So the yellow light area would be typically adding or modifying components. So this might be, adding a couple of sessions to be more specific to a particular community's needs, or changing the order of sessions. Again, you want to have a reason why you're doing it, but it can be shifting what's going on a little bit. It could be changing who delivers the program. So again, if it's master's level, if you're able to work with the developer, will they allow you to use someone who's currently a master's student to deliver the intervention? Again, with approval. Red light changes are the most concerning. And this is anytime you change what we would consider those essential components. You're making fundamental changes to the intervention itself. This would typically be anytime you're taking anything away. So if the session, if the program is usually 18 sessions and you want to cut it down to 12 and cut out that content, that's usually a big problem because you're removing part of the intervention. It could be cutting the timeline, cutting the dosage. So anytime that you're removing things from an intervention, we would call that kind of a red light, and very clearly you've got to talk to the developer to make sure that you're still getting the appropriate intervention. So this is all a piece of working with the developer to meet the needs of your individual situation. Okay. And then, as I mentioned earlier, kind of the last piece of this exploration phase, as you select an intervention, is going to be putting it all in writing, summarizing what you did. We've got some templates on the Cebc that you can use. But most agencies are familiar with writing up those results. What was the process? Here's notes from meetings that we had. Here's attendance lists, et cetera. Having all of that available to support your decision making. One of the key reasons why we definitely recommend keeping written materials, keeping a record, is that we know there's a lot of turnover. And you don't want something to be derailed. If you've got a 6-month effort, you don't want it being derailed because there's been a turnover in leadership and there's no record of exactly what was already decided and why. So make sure you're keeping that going. Okay. So that is a very quick summary of how you can use the Cebc and our tools to help you identify and select interventions, look at the issues that you're having and help you determine what the appropriate responses could be for your agency. And again, we talked about them in the context of FFPSA Part 1, thinking about those 4 different mental health interventions that can be funded under FFPSA Part 1 in California. But you can use the same process for any implementation, any selection process. And for those who are here in California, we are, again, as I mentioned, we're available to help, to provide a little bit more hands-on support for agencies that have questions. We do that typically through phone, through Zoom, and kind of help you work through the guide. So again, the guide, that implementation guide, is the framework, and we just kind of help you work through those steps, answer questions, give support and feedback. So we've got our information here, and reaching out to us at info@cbc4cw.org is the best way to contact us if you would like to access that sort of support. Okay. So that is all the formal questions. So I am going to turn this over to Jess and Dana to see if there were questions that came in or if people have anything else we need to address. It's a lot of information. Sorry, guys.
Thank you. We do not have currently any questions in the Q&A or in the chat, but we can hold a minute to see if, as people process all of that information, if there are things that come up.
Yes, I know. I feel like we spend a lot of time referring people to here and here and here to find more information. So it's a big topic. I think FFPSA has been kind of daunting for years for people. And now we're rolling it out in California. We're trying to get our hands around it, understand more about it. So definitely take advantage of those resources. CalTrin will get those out to you. And then the Cebc, for those of you who are in California, we're here as a resource if you're thinking you might need some support. The state is also doing extensive support, technical assistance support for counties as they're rolling out their comprehensive prevention plan. So there's just kind of a plethora of stuff out there that we can, help direct you in the right area to help you as you're moving forward with this plan. Oh, and I did want to point out, we're going to do a similar summary of the in-home parent skills-based trainings, the program, and also the substance abuse prevention and intervention programs in the coming weeks. I think Dana's probably dropped those links to those registrations already.
Right now.
Okay, thank you.
And I do want to point out that Elizabeth has dropped the prevention services mailbox in the chat as well.
Thank you. Excellent. Yeah, so many resources. So please, if there are people who have questions, there's somebody who can help. Reach out to someone and they will figure out who to connect you with for your community, your region, someone who can help you with questions that you have.
And we do have one question, Jennifer. The question is, can you speak about President Biden's budget that said FFPSA should fund supported too also?
Yes. So, I mean, obviously, each state develops a plan of what they're going to support in their individual state. So California, in their first plan that went into the federal government, included all 10 of the well-supported programs at that time. There have been more well-supported programs since then. I think we're up to 14 total. I think the anticipation is that over time we'll expand in California, we'll expand the programs that can be funded under FFPSA. I think what Biden is getting at is, I think, a reaction that many people in the field have had, which is that the well-supported programs are not all you should use. There are many interventions that are out there. The well-supported programs often get picked because they have the best funding match, let's just be honest. So depending on your particular need, one of those 4 mental health interventions we just talked about may not be the best fit for what your community or agency needs. That just means you can't fund it under FFPSA Part 1 at this time if you pick something else. That doesn't mean you shouldn't pick something else. What I think we hope to see is a recognition that it's not just the rating that should be driving the interventions that get selected. It really should be the needs of the community and what is the best fit for each individual community. And I think what Biden's trying to point out is don't let the rating drive completely the interventions that you select. Pick things that are best for your needs. That's actually, I think, one of the reasons why California, by putting AB 153 in place, they've broadened what you can fund. So there are more things that you can do now if you opt in to this comprehensive prevention planning process to access additional dollars to fund things that can't be funded under FFPSA Part 1. So I hope that answered it. I can go off on using ratings to drive decision-making a lot, but I hope that you got a flavor of that. It's not just the rating. You want to pick what you need.
We appreciate that you have joined us today. And while you are opening that survey, you can also mark your calendars, as Jennifer mentioned, for the 21st of April, which will be the review similar to this one, but on the in-home parent skill-based programs. And then on April 28th, we will cover substance abuse prevention and treatment programs. We are very glad to have had you all, and we look forward to seeing you all again in the very near future.